Good morning and welcome to Healthier Washington Medicaid Transformation, a review of year one and a look ahead. My name is Laura Kate Seichkin and I am the Deputy Chief Policy Officer at the Healthcare Authority. As the title suggests, today we will look back at the first year of the Healthier Washington Medicaid Transformation, and then we'll look forward to the work of the next 4 years that will lead to an improved health care system for our state. So before we start, we'll touch on a few housekeeping details and make some introductions. So first, if you are hearing me and seeing things on the screen, it means you are connected to the webinar. Once you're connected, you have two audio options. You can either connect through your computer's microphone and speakers, or you can dial in using a telephone. And then we are going to be taking questions throughout the webinar, although we will be waiting to answer them until the end. So if you have any questions at any point throughout the web meeting, please submit them using the questions panel, and then we'll answer them at the end of the webinar during the Q&A period. We have a couple great presenters today. Mark Province is on the line. He is the Director of the Office of Medicaid Transformation at the Healthcare Authority. And we also have the Rector, who is the Director of Home and Community Services with the Department of Social and Health Services. Again, I'm Laura Zeichkin, and I will be playing MC today. So, getting in here, we're first going to talk about Healthier Washington overall. The Medicaid transformation sits within the Healthier Washington movement that the state and public and private partners have been moving forward for many years. Healthier Washington is a multi-partner initiative that embodies the state's commitment to improve the health of our people in Washington state and our communities. Its partners include state agencies, community organizations, tribes, managed care organizations, and a wide variety of providers. There are multiple implementation mechanisms to complete and advance these three aims that you see here on the screen. And those include some foundational legislation that was passed in 2014, a $65 million federal grant to focus on the broader payment and delivery system and health aspects in Washington state. That is actually now the grant is in its final month. We have philanthropic support and the topics of today. In January of 2017, Healthier Washington embarked on a 5-year effort to transform the state's Medicaid program. And that effort is called the Healthier Washington Medicaid Transformation. So the Healthier Washington Medicaid Transformation is a 5-year partnership between Washington State and the Federal Centers for Medicare and Medicaid Services, or CMS. The federal government is investing up to $1.5 billion to support Washington's vision of better service for Washington's Apple Health or Medicaid beneficiaries. In this 5-year period, so 2017 through 2021, Washington will demonstrate that it is possible to give people better health care while spending dollars in a smarter way. You can see the Medicaid transformation goals here on the screen, and they very much align with and support those broader Healthier Washington aims that you saw earlier. Washington's goals within the Medicaid transformation over the next 5 years are to embrace whole person care by integrating physical and behavioral health purchasing and care. We have a goal to convert 90% of Medicaid provider payments to reward measurable health outcomes rather than the traditional fee-for-service model. We have a goal to support providers as they adopt new payment and care models. We have a goal to adopt strategies that build health equity so that Medicaid beneficiaries, regardless of where they live, what language they speak, or what their racial or ethnic backgrounds are, have equal access to health services. So by eliminating healthcare disparities, we are looking to support that triple aim and really importantly, support families and strengthen communities. We also have a goal to provide services to support our aging population, those who suffer from chronic illness, and people who lack the social conditions that support health conditions such as stable housing and reliable income. The Medicaid transformation focuses on 3 interconnected initiatives. Initiative 1, also called Transformation Through Accountable Communities of Health, responds to the fact that our health and the care and services we receive is often shaped by where we live. Improving health care for all of Washington's people, whether they live in big cities, small towns, or rural areas, requires regional understanding, experience, and advocacy. We have 9 regionally based accountable communities of health that are the hubs for this work. Initiative 2, also called Long-Term Services and Supports, allows the state to offer new services, including services and supports for family caregivers that help people stay at home and delay or avoid the need for more intensive care. And then Initiative 3, or Foundational Community Supports, creates new benefits to help our most vulnerable beneficiaries learn the skills they need to find housing and jobs and keep them. These new services embrace the reality that without stable housing and income, it is extremely difficult for people and their families to stay healthy and be healthy in the years to come. So with that, we're going to do some deep dives into those 3 initiatives. We're going to start with Transformation Through Accountable Communities of Health. And to do that, I will turn this over to Mark Providence, who will talk about accomplishments in 2017, and then also look forward to the years ahead. Mark.
Thanks, Laura. So in keeping with the theme, I wanted to do a little bit of review of our many accomplishments together with our partners during 2017, and then look ahead to the current and coming years with a particular focus in this segment on Initiative 1, which is Transformation Through Accountable Communities of Health. We did accomplish a lot in our first year, and what are indicated on this slide are some of the key events and milestones. Those that are above the arrow are really kind of more outward-facing activities. Those below the arrow are activities that have been engaged largely within Healthcare Authority and our partners at DSHS. So with that, let's go to the next slide. I'd like to highlight particular elements along this continuum. So obviously the kickoff was the signing of our contract with the Centers for Medicare and Medicaid Services at the beginning of 2017, which was a key event. As Laura indicated, this is what's called an 1115 waiver. We like to remind people that this is not a grant. What this means is it's a contract with the federal government under which we promise to engage in transformative activities that are rewarded upon the accomplishment of key milestones along the way. It's a 5-year agreement, and it is performance-based. So you'll see evidence of that and our attention to that as we go along. So next slide. One of the early and key accomplishments in 2017 during the first half of the year was a 2-phase certification of our accountable communities of health. And this was intended really to help assure that those organizations were fully ready to undertake the transformation projects that are represented in Initiative 1. This simple box really represents a considerable amount of activity that was engaged in by, I know, a number of folks, probably everyone who's listening to this webinar today. This represents really the key engagement between ACHs as organizations and members of their communities. And in the certification process, really helped to assure that the right organizational ingredients, the right kinds of community relationships were in place so that the ACHs could undertake that significant step of project planning. So moving to the next slide, that project planning really occurred, as many of you know, especially in the latter part of 2017, culminating in the submission by all 9 ACHs of their project plans. This was a significant milestone because it does represent the portfolio of activities that the ACHs are promising to undertake over the course of the remaining years of demonstration. As a reminder, the project plans were completed according to a template that we had put out. The project plans themselves were reviewed by one of our key contractors, our independent assessor. I'll say a little bit more about that in a minute. And as a result of that objective review, we were pleased that all 9 ACHs had their project plans accepted and approved, which really set the stage at the beginning of 2018 for focus on implementation planning. The next slide really is a reminder of what projects were selected and approved for each of those 9 ACHs. Just one point to highlight, I know many of you have probably already visited our website, but if you haven't, you can actually find both the certification documents and the project plan submitted by the 9 ACHs. So you can read through those. And again, diagrams can be a little bit too much of summary in that what this really does represent is a significant amount of work. And for each one of these check marks, you'll find a considerable amount of narrative and attention to needs in the communities of each of these ACHs. So again, I would encourage you to visit the website and take a look at those project plans. You'll see that 2 of the boxes are highlighted here. That's because we did require that every ACH undertake both a bidirectional integration of care project and a project addressing opioid use. Every ACH was required to choose at least 2 additional projects. And you'll see the array chosen across the ACHs. It's interesting to note that all 9 ACHs did choose to address chronic disease prevention and control in their respective communities. So again, we were very pleased with the project plan submissions, with the commitment that the ACHs are making to address these needs in their communities. So moving forward, another key event in 2017 was the commitment of a number of regions to fully integrated managed care, to really taking steps in that direction. And I think, as many of you know, the Healthcare Authority is under a series of expectations from our own legislature as well as from CMS to achieve fully integrated managed care, meaning the integration of physical and behavioral health services in one managed care contract for all of our regions across the state by 2020. So we provided an opportunity and actually a financial incentive for regions to make the commitment to proceed toward fully integrated managed care before 2020, and a number of ACHs took us up on that offer, so that we have represented now the regions including Spokane, Greater Columbia, King County, North Central Washington, North Sound, Pierce County, and Southwest Washington. As many of you may know, Southwest actually took the lead a couple of years ago in adopting a fully integrated managed care approach. North Central is actually actively in that relationship now, and the others are coming along effective January of 2019. So this is a significant commitment by them and was recognized through the availability of some additional incentives under Medicaid Transformation to allow them to get ready. And then finally, above the arrow, I wanted to note a number of activities with respect to collaboration with Washington's tribes. This was a significant investment of time and attention by the tribes in conjunction with our tribal affairs representatives here at the Healthcare Authority, and with cooperation with the American Indian Health Commission as well. And so we're pleased that we're on the way toward developing those tribal-specific projects. In fact, at the end of the year, the tribes had earned an incentive, the first of incentive payments to assist them in their project planning, and those funds have already begun to be distributed. And we're continuing to work with the tribes, with AIHC, and with our partners in tribal affairs within HCA to make sure that tribes can both undertake projects on their own and also to participate in projects that are put forward by ACHs throughout the state. So it's a significant partnership and one that we're very pleased about. Moving forward, and kind of below the arrow, I wanted to highlight a few things that represented significant work on the part of the state. One is that we have had a number of protocols that we have written, submitted, and have been approved by CMS. And those include protocols for project planning, what we call our district planning, and our funding and mechanics protocols. Our protocol with respect to intergovernmental transfers, which represents a significant funding source for the transformation. A description of the role of our financial executor, and I'll speak more to that in a second. A protocol specific to Indian healthcare providers, and a protocol describing our foundational community supports program. And again, all of those documents can be found on our website and become really part of our agreement with the federal government. Next is the recognition that we have a number of key contractors who are partners in carrying out the work under Medicaid transformation. Those include Manat Health, which is an organization that was very instrumental in working with the ACHs during 2017 to prepare and submit their project plans to us. And Manat continues to work with us on a number of aspects of the transformation. We also have a public consulting group, PCG, which serves as our financial executor. The financial executor's role is really to handle the financial transactions between the state, the ACHs, and their participating providers. I think as many people know, there is a portal in which participating providers register, and that enables them to receive incentive payments at the direction of the ACHs. We also have an agreement with Myers and Stauffer. That is our independent assessor firm. As I mentioned, their first task was to review and approve or recommend approval of the project plans. They will also be engaged throughout the remainder of the transformation project in reviewing and making recommendations regarding the semi-annual reports that each ACH will be required, the first of which is due this coming July, and then every 6 months thereafter. And those reports and the measures that are represented in them really constitute the performance activities that in turn generate incentive payments under the transformation project. I also mentioned, or will mention actually, when we talk about foundational community supports, we have a contract with the Mira Group as a third-party administrator for those foundational community supports. And then finally, and this goes a bit into 2018, I realize, but we just announced that we have an apparently successful bidder in Oregon Health and Science University for the independent evaluator contract. And the evaluator's role will be to, as the name implies, conduct an evaluation across all three initiatives over the course of the transformation project, and ultimately make findings and recommendations to the Healthcare Authority and to CMS. A couple of other things in 2017, a lot of activity to create documents and templates and measures that guide the ACHs in not only the creation of their project plans, but currently the work that they're doing in implementation planning. These documents are developed largely in conjunction with the ACHs and with our contractors. There's a lot of back and forth involved, and the documents that we reference end up being available on our website for folks to review. But it's important to note that this is not just a once and done kind of activity. The measures that we're using, for example, are always evolving. The templates, as I mentioned, are often a matter of back and forth between us and our partners, and so we always welcome and encourage feedback on those. And then finally, looking at 2017, a considerable amount of activity in what we call health systems capacity building. Many of you are familiar with the 3 domains that we have in our project toolkit. Domain 1 is really representative of 3 key areas, functional areas, including value-based payment, population health management, and workforce development. These are areas in which we encourage and support a lot of collaboration between ACHs and also between ACHs and the healthcare authority, because these really represent foundational building blocks to carry out the other projects that are represented in the project plans. There's a fair amount of attention to value-based payment, for example, in conjunction with our Medicaid Value-Based Payment Action Team. There's been considerable work by the Practice Transformation Support Hub in helping provider practices in a number of cases really be ready to undertake some of these foundational elements. And we also have developed and are carrying out health information technology operating plan. So again, a lot of ongoing attention in those 3 areas of value, IT, and workforce. So before I turn it over to Bea, I wanted to talk a little bit about what lies ahead for us, especially with respect to Initiative 1. I mentioned project plan implementation. So the ACHs are now actively engaged in developing their project implementation proposals and plans. Those will be due in October of this year. And this really represents the progression from the planning stage in terms of having had their project plans approved to what are the elements that are required to actually implement these projects, so that by the time we come to January of 2019, these projects are all ready to go. The implementation plans will be reviewed by Myers-Stauffer, and the slide notes here, one of the key ingredients of that project implementation development is the work on the partnerships between ACHs and their local and regional providers. We'll also be continuing our measure development, and the 2 types of measures represented in our project are pay for reporting and pay for performance. I think, as some of you may know, there's a heavier emphasis in early stages on pay for reporting, which really means evidence that the ACHs submit to us that really report on the progress they're making toward the initiation and carrying out of their projects. That shifts then to focus more on pay for performance, and that ties to one of our key activities right now, which is the development of our measurement guide. I think many of you know, and some of you probably commented on the measurement guide that we had put out for comment in February. We're currently working with those comments and refining the measures to provide guidance to the ACHs on what they'll be measured on. I mentioned semi-annual reports, again, the first of which will be due this coming July, and then every 6 months thereafter. Continued attention to tribal project development. Ongoing assessment, and this is not just the formal assessment I mentioned through our independent assessor and evaluator, but there is considerable back and forth over time between us and the ACHs and our key stakeholders. We very much see this as work in progress. It's very important for us to maintain those communication channels. And so it's both formal and informal assessment as we go along, because we're all learning from each other in this process. And finally, sustainability planning. It's not too early to begin giving attention to the question of how do the transformation successes through the course of the transformation project get continued beyond the close of this 1115 waiver. So we very much want to avoid a situation in which we come to 2021 and activity ceases. Very much the opposite. We want to start planning now for how we will continue those successes beyond 2021 and really continue them in service to the 3 Healthier Washington goals that Laura showed you at the beginning of the presentation. So with that, I will hand it over to Bea and ask her to talk about Initiative 2.
Thanks, Mark. Again, my name is Bea Rector, and I am the Director of Home and Community Services Division, which is within the Aging and Long-Term Support Administration of the Department of Social and Health Services. Next slide. So many of you probably are aware that our population in Washington, just like the nation, is rapidly aging. In fact, we're going to see a doubling of the number of people who are ages 65 and older over the next 20 years. This chart shows that growth in individuals over age 65 in 10-year increments. And the fastest growing line is the blue line, which represents people who are ages 85 and older. We know from national statistics that there is a direct correlation between getting older and having an increased need for assistance to stay at home independently. In fact, 70% of us that are lucky enough to reach age 65 will need some form of assistance with long-term services and supports in our lifetime. And whether that's served in-home or in a residential or nursing home setting are the types of options available in Washington and nationally to meet those needs. Next slide. So just to give people a reminder about Initiative 2, long-term services and supports, we're really building on a decades-long successful partnership between the Department of Social and Health Services and local area agencies on aging, of which there are 13 in Washington state. The services that we are designing is really intended to delay or avoid the need for people as they age to access more intensive Medicaid-funded long-term services and supports. We're lucky in Washington in that we live in a state that's considered to be a national leader in long-term services and supports. And so as we looked to this demonstration, one of the things that people often ask us is, what are you trying to demonstrate? You already have kind of a world-class system. And really what we're trying to do is figure out, how do you address the needs of an increasingly growing population in a world where the resources or state dollars or federal dollars are not going to grow at the same level as the need for people to access services. We wanted to get at some folks, meet their needs who are not typically eligible for Medicaid. We wanted to introduce the notion of supporting unpaid family caregivers into the Medicaid system. And we also wanted to test something we call presumptive eligibility. So in Washington and nationally, when somebody wants to access services outside of a nursing home, there's federal requirements that to do so the state must first determine functional and financial eligibility for services. And you cannot backdate that eligibility in the way that you can backdate medical Medicaid eligibility. And that becomes a real barrier to people accessing services in the community, because you can backdate in a nursing facility. So there's a nursing facility bias. So being able to determine eligibility quickly in what we call presumptive eligibility is something we think is important to demonstrate at the national level. Next slide. The Family Caregiver Support Program is a program that we have been operating in Washington state for over a decade. We know that when we wrap services around a caregiver, it produces positive outcomes for both the caregiver and the person that they're caring for. We know from our past studies that use of Medicaid-funded long-term services and supports is reduced by almost 20% when you can wrap services around an unpaid caregiver. We also know that 85% of those caregivers experienced improved outcomes. They have reduced stress, reduced burden, reduced levels of depression, and increased satisfaction with their relationship with the person that they're caring for. Many caregivers have chronic conditions and age factors that make them likely enrollees in Medicaid. And so wrapping services around that caregiver also shows that we can achieve reductions in the need for the caregiver to access Medicaid-funded long-term services and supports. So we're going to talk next about where we've been. We launched these two new programs in September of 2017. The two programs are geared towards, again, providing a new option for individuals who are Medicaid eligible to receive long-term services and supports. Again, wrapping those services around an unpaid caregiver to support them in caring for their loved one. And that's the Medicaid alternative care. The second program, Tailored Services for Older Adults, is geared to reduce the need for individuals to spend down out of their savings and impoverish themselves to qualify for the services they need on Medicaid. In Tailored Services for Older Adults, or TSOA, we can wrap services around an unpaid caregiver. We can also wrap services around somebody who may not have an unpaid caregiver. Program eligibility for these two programs. We are targeting the aging population, so that age eligibility for these programs is 55 and older. For the Medicaid alternative care, again, this is focused on somebody who is already on Medicaid or could be Medicaid eligible. So they're receiving categorically needy or age blind and disabled, Apple Health or Medicaid. They meet functional criteria for being able to be served in a nursing home, which means they need hands-on assistance or verbal assistance with daily living tasks such as bathing, medication reminders, walking, eating, things like that. For the Tailored Services for Older Adults, again, still the 55 plus population. And these are individuals who have too many financial resources to qualify for Medicaid. Their income has to be less than $2,250 a month, but they can have more resources than typical. They can have, as a single person, up to $53,100 in resources, and if they're married, because of spousal impoverishment rules, the couple can have up to $108,000. Again, meeting that same functional criteria of needing assistance with daily living tasks. And folks on the TSOA program would submit a financial application so that we can determine eligibility for the program. There are a number of services that people are able to access through this program. The green box, caregiver assistance services, these are services that take the place of a caregiver. Things like a bath aid to come in and help someone take a bath. Someone to provide personal care services if they are somebody without a caregiver, or household and errands. The yellow bucket, training and education, are things like support groups, training a caregiver on the skills and competencies they may need to care for their loved one. Also, providing education on the importance of self-care when you're a caregiver. The orange bucket, those are really things like bath benches, incontinence supplies, things that insurance may or may not cover, and also trying to reduce out-of-pocket expenses that caregivers experience. In the red bucket, health maintenance and therapy supports. These are things like physical therapy, occupational therapy, stress relief for the caregiver and counseling. And then lastly, in the brown box, for people without caregivers on the tailored services for older adults, we can provide a small level of personal care assistance for folks. This slide is a little bit busy, but what it shows you in this early stage of implementation is what services are people actually accessing. What are the top 10 services people say are important to them to stay in their homes? CR stands for care receiver, so that's the number of people receiving or authorized for the service, and the amount is in dollars. So you can see personal care and respite are amongst the top services used. Housework and errands and personal emergency response buttons, the I've fallen, I need help getting up, the med reminder, that's the second bucket. Getting respite outside of your home and in maybe an adult day setting, that's pretty common for people with dementia or traumatic brain injury. Getting your home adapted, doors widened, ramps so that you can get in and out of the home safely. Next, bathing assistance and home delivered meals. And then lastly, durable medical equipment, things like raised toilet seats, grab bars to make the house more safe for somebody, and a personal emergency response system with a fall detection, so that if people are alone and fall, rather than pushing a button, we can actually know that they fell in today's technology and call somebody that the individual has identified to come check in on them. The numbers here are fairly small in some of these categories. Keep in mind that we're new in enrolling people and we expect these numbers to go up over time. The next slide shows the number of people that we're serving by month. You can see the number is climbing month to month, and that's what's to be expected. That's what we want to see. These are active authorizations. So if we look, in fact, at the number of people that we've touched since September, we actually have over 1,000 people who have accessed some amount of services. Keep in mind that some of these services, somebody might just need a one-time training on skills and competencies, or they might just need a referral to a support group, or they get that personal emergency response button and that's what they need and off they go, and they don't get ongoing services, but they might come back later if their needs change and they need additional services. Next slide. So looking forward, a big piece of what we're doing is getting the word out about these programs. These are expanded programs, in some cases new programs, and just making sure that the public is aware of them and knows how to access services is a big piece of the work that we're doing. So there's 2 doors that people can enter. They can call their local area agency on aging. We have a 1-800 number statewide that is on your slide if you want to get that out to people you know who might benefit from these services. You can always look up Area Agency on Aging in Google, in Yellow Pages, those types of things. And then secondly, you can always call a DSHS Home and Community Services office. We have resources on our website, and you see some links there for that as well. Rosalind Carter is a real advocate of caregivers, and she has been for years, and she has a quote that I love, and that is that you have either been a caregiver, you are a caregiver, you will need a caregiver, or you will be a caregiver, and that caregiver is really something that touches all of us. We have over 850,000 unpaid caregivers in Washington State. It's a very frequent conversation around the dinner and lunch table that you all might be having because we are experiencing lots of people aging. The challenge is that people who are caregivers do not identify themselves as such. They see themselves as a daughter, a son, a family member or friend who is just doing something small to support somebody they love. Examples might be help paying bills, help taking you to the doctor's appointment, help setting up medication sets, or just checking in a couple of times a day to make sure that your loved one is fine. You call that being a good daughter, son, family, or friend. We call that caregiving. So we have a caregiving campaign that is launching. You will see these kinds of messages on the sides of buses, on public TV channels, newspapers, etc. And this is really, again, a big piece of what's coming next, is just making sure that people understand that there are resources available to help caregivers. We have lots of materials available on our website. The Healthcare Authority Medicaid Transformation website is the repository for all of the official waiver information that you might need, and we have some long-term services and support specific materials on that webpage. We also have information on the DSHS webpage. And Columbia Legal Services is a legal advocacy organization that we work with quite closely, and they have developed a question and answer document that helps the public understand the MAC and TSOA programs and why these programs might meet somebody's need, or why somebody might want to really access traditional Medicaid long-term services and supports as well. Again, additional resources for caregivers are available. Local contact information on this website, brochures related specifically to these programs. And lastly, we've got some contact information for our 2 key program managers that work in Olympia that are helping get the word out. And I want to say that like Initiative 1, sustainability planning is a huge piece of what comes next. Being able to measure the cost effectiveness, the impacts, both from a health perspective, a dollar perspective, a quality of life perspective. We have a very robust evaluation plan wrapped around Initiative 2, similar to the other initiatives. And we're really looking forward to see some of the early outcomes of surveying that we're doing with people receiving the services and their caregivers, and to seeing how many people we can touch through this program. So I'm going to turn this back over to Mark, who's going to talk about the foundational community supports, or Initiative 3.
Thanks, Lee. So just to round out in the third of our 3 initiatives, talking about foundational community supports, which are supportive housing and supported employment services. I want to note, and I think, again, many of you are probably aware of this already, that 2017 was a pretty eventful year for us in that it really engaged us in negotiations with our partners at CMS in working out the details of what these foundational community supports really represent, because this is very groundbreaking work. We're excited because it really throws a spotlight on our attention to whole person care, recognizing that so much of what constitutes health and health status for the populations we serve goes beyond just the traditional caregiving setting and really represents those basic needs, including housing and employment. So we're very excited to have foundational community supports as part of our Medicaid Transformation project in Washington State. So moving to the next slide, just a little bit of review. The initiative really provides support for housing and employment. It does not, as I think many of you know, provide subsidies for wages or room and board. It doesn't represent paying rent or building housing, but these really are support services intended to make it easier for people to obtain and maintain stable housing and employment relationships in their lives. Looking at the next slide, who's involved in foundational community supports? This really is a collaborative activity, as is represented by this slide. Certainly starting with our relationship with CMS and the inclusion of this initiative in our Medicaid Transformation project, with Healthcare Authority really representing the link between the federal government and their expectations and the implementation of these supports at the community level, and in very close partnership with our partners in DSHS representing behavioral health and aging and long-term services. As I mentioned earlier, we have a contract with Amera Group as our third-party administrator. This was a competitive procurement for an entity that could serve to carry out the functions that are represented here: contracting with foundational community supports providers, managing client referrals and authorizing services, distributing provider payments, and very importantly, tracking the data that will become very important for us to monitor to know the difference that these services are making as we progress along the remaining years of the transformation project. And finally, none of this could happen without foundational community supports providers throughout the state, represented by the boxes that you see at the bottom of this slide: community-based organizations, healthcare providers, community behavioral health agencies, long-term services and supports providers, and tribal providers. So again, a very collaborative and inclusive activity. Looking at the next couple slides, just a review in terms of services that are available. So for housing, as you can see from the list here, housing assessments and planning so that we can identify the opportunities for housing for the people we serve, outreach to landlords, connection with community housing resources, assistance with housing applications, and education, training, and coaching around such things as resolving disputes with your landlord or advocating for your needs, the kinds of things that some of us may take for granted, but that are very important, again, in terms of maintaining stable housing relationships. Looking at the next slide, in terms of employment-related supports, again, assessments and planning so that we can help the individual find the right job at the right time, outreach to employers, the very important element of really having that network of contacts that enable the link between an individual and their needs and their skills with the jobs that may be available, connection to community resources, assistance with job applications, similar to assisting with housing applications, and education, training, and coaching to keep folks in their jobs. So again, the necessary and sometimes overlooked support services that help people really obtain and maintain those stable housing and employment relationships. So in terms of eligibility, who is eligible to receive these services, there are really two key elements in addition to qualifying for Medicaid and being at least 18 years old. And those elements really focus on healthcare needs, health-related needs, and risk factors. So you can see in the bullets at the bottom, especially medical necessity related to mental health, substance use disorder, issues with activities of daily living, or complex physical health needs that could prevent someone from functioning successfully or living independently without the supports that these services provide. And then risk factors that may prevent folks from finding or keeping a job or maintaining a safe housing environment. And with regard to those risk factors, those are illustrated on this slide. So as you can see on the housing side, things like chronic homelessness, frequent or lengthy stays in institutional settings. On the employment side, difficulty obtaining or maintaining employment for a number of reasons, serious mental illness. So again, it's the combination of an individual's health needs, but also these key risk factors that really help us to zero in on the populations that we feel are most in need of the kinds of supports that the transformation project can provide. So I mentioned AmeriGroup and their role as a third-party administrator, and that really involves these key functions. They are under contract with the Healthcare Authority and accountable to us, but they provide administrative oversight in the areas that are listed here, maintaining the provider network, and we are grateful to our partnership with our DSHS partners in identifying a lot of the providers who really are out there able and interested in being part of this foundational community supports network. Service authorizations, claims payment, measuring outcomes, and helping us in that ever important plan for sustainability of these services beyond the conclusion of the transformation project. AmeriGroup also has a Foundational Community Supports Advisory Council. And if any of those listening to this are interested in more information about the Advisory Council or how one would become a member of that, please contact AmeriGroup directly. I believe we have contact information either as part of these slides or on our website. Looking at how folks receive Foundational Community Supports benefits, this is a little bit of a busy slide, I realize, but the thing to emphasize here is that there really is no wrong door in terms of access to these services. Anybody needing these services can contact AmeriGroup directly, and similarly, any provider or advocate, family member, friends, others can refer an individual that they believe could benefit from these services. On AmeriGroup's website, there is a quick reference guide that can help with the referral process. And once a person is referred, AmeriGroup assigns the individual to a contracted Foundational Community Supports provider for assessment, and then AmeriGroup will use that assessment to confirm their eligibility and then authorize services. So looking at kind of how we got here and where we're going, as a reminder, these foundational community supports were part of our original application to the federal government. As I mentioned, it really took us the length of 2017 to negotiate with CMS around the definition of the services and the eligible populations, but we were delighted at the close of the year to finally receive approval from the federal government to put this into action. And so really 2018 is focused on outreach to clients, contracts with providers through AmeriGroup. It's really building that network and getting people familiar with the kinds of services and supports that are available. And then finally looking ahead, what are we working on? We really consider the early part of 2018 as kind of a soft launch. Again, so much of this ends up being kind of, building the plane as you're flying it. Because we were needing to spend really all of 2017 with the negotiation, we got a bit of a later start than we would have liked, but things are underway. And as you can see on this slide, we have over 60 contracted providers now and are providing service. I think it's now roughly 250 or more enrollees receiving services, which is really gratifying, and activity continues to grow. So we're delighted that we're underway, and we'll keep focusing on moving ahead. I think there's one additional slide in terms of future focus. This year really focused a lot on access. Again, it's outreach to those who are potentially eligible. It's making sure that the provider network is there, that the referral relationships are working. We monitor very closely with AmeriGroup how people are responding to the availability of these services, and that means both clients and providers. A lot of the focus moving forward will be on making sure that we've developed the appropriate quality standards and have continuous quality improvement so that we can make sure that we're moving in the right direction and in the development of the services, and also contributing to the overall evaluation of the success of Medicaid transformation. And then ultimately, as I mentioned, sustainability of these services. With the investment that we're making, with the investment that many of you are making in the success of this initiative, we want to make sure that we can not only demonstrate its success, but by doing so can incorporate these as ongoing supports that are available to these folks who are especially in need. And then finally, in terms of contacts, John Brumbach's name is listed here. John is taking the lead at HCA for the Initiative 3, Foundational Community Supports and Services. I would also like to acknowledge the tremendous help and partnership in behavioral health, especially with Melody Pazolt, and in aging long-term services, and Kelly Emmons. So again, it's very much a collaborative and interagency effort, and we're grateful for the partnership that we have with our sister agency. With that, I will hand it back to Laura.
Thanks, Mark. So we have about 30 minutes or so to answer as many questions as we can get through, and we've received several already during the webinar. So again, here's a reminder that if you have questions, please use the questions pane in that webinar panel, and we'll be taking them and seeing them as appropriate here. And I also just want to note that in addition to having Mark Province and B. Rector here to answer questions, we do also have Melody Pazolt from DSHS who can chime in on Initiative 3 or any of the initiatives. So Mark, I'm going to send the first question to you here, and it is around oversight of Initiative 1 and the Accountable Communities of Health. So the question really is around how the healthcare authority, how the state and the accountable communities of health and their partnering providers are achieving targets. What is the oversight mechanism, and how are the accountable communities of health partnering providers and the state working together on that?
Thanks, Laura. So a couple of things, just to I think contribute to the ingredients of oversight, if you will. So first and foremost, and I'm kind of starting from the top, is our accountability to CMS, Centers for Medicare and Medicaid Services. We produce a quarterly report to CMS on our activities. And I believe we make those reports available on our website as well. And so it's our way of making sure that we're holding ourselves accountable to the special terms and conditions that really constitute the contract that we have with CMS. I would also note, of course, our accountability as agencies, both HCA and DSHS, to our own authorizing environment. That's obviously our state legislature and governor's office. We have regular contact with legislators and legislative staff. They're very interested, obviously, in how we're doing, in how we're reporting on how we're doing, and making sure that we're being good stewards of public resources. A couple of other ingredients that are important. One, as I mentioned, the independent assessor. The ACHs in Initiative 1 are responsible for submitting a semi-annual report to us. So every 6 months, they must report to us on how they're performing, how their projects are performing. And I mentioned the combination of the pay for reporting and pay for performance measures that are represented in our measurement guide. Those really represent key mileposts that we use for assessing how well the projects are proceeding, and also how well the ACHs and their partners are performing relative to expectations. I mentioned as well the independent evaluator. So in addition to the ongoing work of the independent assessor, the evaluator will be responsible for taking a look, say, at a bit of a higher level, but across all of the initiatives of Medicaid transformation, to make sure that, in fact, we're performing to the expectations of the STCs and achieving the outcomes that we've committed to. And finally, I'll note that one of the requirements under our relationship with CMS is that there is a midpoint assessment. So basically halfway through the transformation project, we will be conducting an assessment of how the transformation projects are doing, just to make sure that it gives us one more formal opportunity for assessment, course correction, with respect to those transformation projects. And I guess one additional point, if I may, and that is, I mentioned earlier the ongoing communication that we have with our ACHs. We have essentially, weekly conversations with the ACHs and their executive directors, their finance folks, communications people, to make sure that above and beyond the formal assessment processes, we're in constant communication with them and able to, on a real-time basis, answer questions, provide guidance and intervention if necessary. So I think it's that combination of activities that really assures us of the level of oversight that's necessary in an important project like this.
Thanks, Mark. So B, we have a couple technical questions about MAC and TSOA, so I'm going to give you the first one is around the eligibility and the resources that are associated with eligibility. Do those numbers that you provided around total resources include home, car? What's included there?
So it's important to know that cars of a certain value are excluded from Medicaid eligibility determination, as is a home under a certain mortgage level that somebody is living in or owns. So those are things that are typically not included in regular Medicaid, and therefore they also would not be included. The kinds of resources that we're talking about are typically things like retirement, stocks, IRAs, savings accounts, those types of things.
Great. And then another somewhat technical question. Are the MAC and TSOA services covered through managed care, or are they reimbursed fee-for-service?
So long-term services and supports is largely a fee-for-service operation in Washington State, and the MAC and TSOA is also delivered through a fee-for-service purchasing arrangement.
Great. So Mark, that gets us to a question just about one of those overarching aims of Healthier Washington, and one of the major goals of the Medicaid transformation, and that's around value-based payment. We have a question about what we mean by value-based payment and how it is measured.
Great question, and one that I think is the focus of ongoing discussion. What we mean, let me give a couple answers in terms of what we mean by value-based payment. At a simple level, if you will, we have defined value-based payment using a format developed by the Healthcare Payment Learning and Action Network, or HCP-LAN, which is a federal, or it's a national initiative really to define really a progression of financial and performance relationships ranging from traditional fee-for-service at one end all the way up to population-based reimbursement at the other. So for those of you who may be familiar with the HCP-LAN scale, there are 4 categories, and we've defined, for purposes of at least having a visual and a yardstick, that value-based payment for us means any kind of payment relationship, financial relationship between a payer and provider that goes from what's called Level 2C, which is really an enhanced, it's more than fee-for-service, but it's rewards for better performance all the way up to Level 4B, which is really population-based reimbursement, or what is often referred to as capitation. That's kind of, and as I say, that's a bit of a shorthand response, because really for us, what value-based payment really means is it's the results that one achieves, both in terms of the performance of the healthcare system, but also healthcare outcomes and health status, relative to the size of the financial investment that's made to achieve those, with the idea being that we need to maximize that return, and not to make this sound too fiscal, but that return on investment. So value really translates, and this goes back in part to the triple aim. It relates to not only, did a patient have a favorable outcome for a particular encounter with the healthcare system, but really, is the patient, and more importantly, is the population getting better? Are they performing better in ways that we can measure? Now, ways that we can measure is often a challenge, because there are certain kinds of outcomes that are more difficult to measure than others, because they aren't necessarily represented, say, in insurance claims. But using the data that we have, using the relationships that the ACHs have with their communities, we're always seeking to sharpen our focus on what defines value, and then how can we relate that value outcome to the investment that's made. And so in terms of measures, one way we're starting is the state has developed a common measure set, which takes advantage of data that are available that represent certain kinds of outcomes and results of largely of the healthcare system, but also measures of health status that we can use and that focus in important areas like chronic disease, but measures that we can use at least at this stage to know whether we're making progress. And finally, I'll note progress really, we measure outcomes in two ways. It's very important for us not only to know what level of achievement has been made, say, in a given ACH region for a given project, but also what's the progress demonstrated from point A to point B. So it's both achievement and performance. So in all of those ways, that's how we're focusing on value-based payment and how we're trying to measure it.
Thanks, Mark. So picking up on that thread, accountable communities, or I should just say communities, regions, and then also the state are being rewarded under the Medicaid transformation for hitting value-based payment targets. One of the goals of the Medicaid transformation is to hit 90% of value-based payment in state financed arrangements by 2021. So kind of following that, it says that the accountable communities of health as the lead entities are the ones that are being rewarded for hitting those targets. But perhaps you can dig a little bit deeper into the role of the accountable communities of health in advancing value-based payment, and importantly, what the partners' roles are around the table in advancing that.
Sure. I will take a stab at that. The role of the ACHs, and it's important in one sense to distinguish their role, say, from the managed care organizations. As I think many know, we deliver our Medicaid services under Apple Health through contracts with MCOs, managed care organizations, and they in turn contract with providers. And so in that sense, it's a straightforward financial relationship. We reimburse the plans. The plans in turn reimburse the providers, and within the contracts that the MCOs have with their providers, they're able to set certain expectations and specify means by which providers can be reimbursed and can earn additional incentives. For the ACHs, it's a bit more interesting, and remembering that ACHs are relatively new organizations, there isn't the same kind of contract necessarily between an ACH and a provider. So to the question, what can the ACH do? What do we expect the ACH to do? a lot of it really is in helping to provide supports for providers to be able to and ready to undertake those progressive reimbursement risk and reward relationships with their MCOs. So let's say, for example, that a particular provider in a given community is really orienting itself toward value-based payment, but needs some additional help in terms of knowing how to capture the performance data that they'll need to demonstrate to a payer, to an MCO, that they're actually delivering on their promise. The ACH could partner with that provider in providing some incentive dollars that would help build the capability to gather and report on those particular kinds of measures. Similarly, if one thinks about value in terms of maximizing the outcome of using personnel kind of at the maximum ability at the top of their license, if you will, it may be that a particular practice can extend its resources by engaging the support of caregivers, care providers at different levels. And it's a matter of securing the right training that it's going to need to make sure that those people are performing at the top of their license. Because that's oriented toward delivering more value for the investment, that could also be an example of how an ACH could partner with its providers. And then finally, since not all providers, and if we think about providers very broadly, necessarily have a history of contracting with MCOs for reimbursement, ACHs may also work with some of the less traditional, if you will, if I can use that word, providers in terms of relationships with MCOs, and help them figure out how can they engage in relationships, how can they determine what's a reasonable type of relationship to have with an MCO, again, recognizing that the services that those providers deliver are actually providing value relative to the investment that's being made. So I think in those various ways, we're looking to ACHs to work with their provider community to be ever more ready to engage in those kinds of value-based payment relationships.
Thanks, Mark. Those are really good examples. And I think in short and in very general terms, the flow is the plan holds the providers accountable for outcomes. The accountable community of health is the table that has providers and plans and community supports around the table to identify the resources and supports that are needed to achieve those outcomes. All right, moving back to Initiative 2. B, you spoke and shared some information and some snapshots of really the campaign to promote these new services under MAC and TSOA. We got a question about what the provider community's awareness is and how we can spread the word even more and spread awareness even more through the provider community about the availability of these resources.
That's a great question. And of course, we have our provider community in long-term services and supports that we've shared information with. However, we know from surveying caregivers that typically where they would think of going to ask for assistance is really the primary care doctor. So I do think that as we move forward and as we look forward, we need to find ways to get this information out to a broader group of providers than we have traditionally worked with in long-term services and supports, including hospital discharge planners and primary care physicians. So anyone on the phone who can help us get the word out that you have connections with, certainly the accountable communities of health and their tables would also be a great way for us to get this information out. We can share the campaign materials, brochures, etc. If you're willing to distribute them, or if you have ideas about how to access those providers, emailing Kim or Debbie, whose email contact was in our presentation, they would love to get that information.
Thanks, Bea. And those slides will be available if people need to go back and revisit that contact information or any of those resources. So take a look at the HCA website when following this webinar. Mark, we're getting back to you. There is a question about data, and specifically, there's a question about what data the accountable communities of health have, and what support the 9 ACHs will have in performing data analysis, having access to data. So how are the accountable communities of health, state, and others working together on those aspects?
Thanks, Laura. So data really represents kind of one of the key ingredients to demonstrating success, measuring performance, and ultimately helping to assure sustainability. And there are probably a number of different components to this question. I'm not sure that I can speak to all of them, but I'll certainly try. In terms of support for the ACHs, we at the Healthcare Authority, through our AIM team, which is Analytics, Interoperability, and Management, have committed to essentially pushing data out to the ACHs via dashboards and other means that we have to share what we know about the Medicaid populations that are served and enrolled with MCOs in the various regions, and what we know about the activities and use of services represented by that population. And so our AIM team is very closely involved with the ACHs. There are regular communications between the AIM team and data representatives at the ACHs, and that will continue. And I should also mention a strong partnership between our AIM team within Healthcare Authority and RDA, Research Data and Analytics, within DSHS. We also recognize, and this gets back to a bit to an earlier question in terms of kind of related to what I was saying about value-based payment before, ACHs do have the ability, in working with their partnering providers, to make sure that if there's support that's needed in order to enable a partnering provider to more effectively report on the care, the outcomes, the health status of individuals served, if there are needs to support that with respect to health information exchange, HIT capabilities, that's a reasonable use of incentive dollars that are available through Medicaid Transformation. I'm not suggesting that every ACH can afford to go out and buy a electronic health record system for every partnering provider, but given that providers are already moving along that, moving toward that need to be able to more effectively report on outcomes and care delivered, the incentive dollars under transformation provide some additional resources that can be put into that pursuit. I mentioned the measurement guide, and I recall that for purposes of answering this question, just as an indicator of the kinds of things that we're seeking to measure and the kinds of data that we're committed to helping the ACHs have access to in order, again, to determine whether they're making progress in their transformation project. So I guess that in summary, the foundation for our relationship with the ACHs in terms of data really starts with the activities of our AIM team and of RDA, and our commitment to making those data available to the ACHs as we move forward. There is an HIT operations plan that we have put together. Again, I believe that's available on our website. that provides a little bit more of a description of the roadmap, if you will, the steps that we're taking to make sure that that the data will be there in order for us to evaluate. And actually, speaking of evaluation, that's one other thing, is through the partnership that we have with our independent evaluator, we'll be working to identify and confirm what kinds of data sources are available, not only to them, but are being made available to the ACHs, so that we can have continuous improvement in performance and quality. So I realize that's a bit of a rambling answer, and it's probably obvious from my answer that I'm not necessarily the data expert, but those are fundamental activities we're engaging in to help the ACHs.
Thanks, Mark. And then we just have a final question for you, and that is, how can providers, so clinical providers, behavioral health providers, community-based organizations, public health, how can they get involved in this work at the community level?
Well, that's a pretty straightforward answer to that question, is seek out and become involved with your local ACH. A considerable part of our expectation with respect to the organization and performance of the ACHs is that they are actively engaging their provider communities in the design, development, and ultimately the implementation of their transformation projects. So perhaps one important step would be for any provider who is interested in kind of a deeper engagement with the ACH, I'd suggest a couple things. One would be, take a look at the ACH's approved project plan on our website. And as a reference, and we'll make these slides available, I know, but you can go back to the slide I showed earlier, that those checkboxes that show which projects are being undertaken by which ACHs. So if, for example, you're a behavioral health provider, you would know that regardless of where you are, your ACH has committed to a project that integrates physical and behavioral health services. You can look at the ACH's project plan to see specifically how they intend to carry that out, and use that as a basis to engage in a conversation with your ACH about how you as a provider can become involved in making sure that that project is successful. So again, in summary, I would say the ACH is absolutely your point of contact with respect to engagement in those projects. I would also recall, by the way, with respect to Initiative 3 as well, if you are a provider in the sense of providing support services related either to housing or employment, I also encourage you to get in touch with the Mera Group if you're interested in engaging in those services as well.
Thanks, Mark. And yeah, just to reiterate, certainly at this point in year 2 of the Medicaid transformation, now is the time for providers, both traditional and non-traditional, to get engaged either at the accountable community of health level, or yeah, again, if you're providing the services under Initiative 3 or 2, then now's the time. All right, well, I want to, before we leave today, make sure that those who are interested in staying informed and being involved at a statewide level know how to do so. So we have a Healthier Washington Feedback Network, and you can join that list to receive regular emails at the website here on the screen. We are always looking for public comments and feedback on how things are going, and there were many contacts that were listed here today to provide that kind of feedback. We have many resources on our website, hca.wa.gov/HW. And some of those resources include a Voices of Healthier Washington platform that is web-based and shares stories from people who are either working in or affected by a lot of the work that's advancing through a Healthier Washington. Always please feel free to join the conversation via Facebook and Twitter, #HealthierWA. I want to thank our panelists today. Thank you, Mark and Bea, for joining us and providing such a comprehensive update. And thanks to everyone who joined the web meeting today. We appreciate your work and partnership in advancing a healthier Washington.